Manipulation and back-related leg pain. A few years ago, there was little literature evidence for the use of manipulation in the management of patients with back pain and associated leg pain. In fact, there was a strong concern that it would likely worsen patients with this presentation based on an assumption that first, leg pain was disc-related, and secondly, that manipulation could potentially extend the already existing damage. Yet since 2011, there has been mounting evidence that not only can manipulation be safely applied to these patient presentations, but that it may also be an effective management tool, in particular for the decrease of symptoms in the short term. And yet another study has recently been published, the focus of this presentation. It's entitled Spinal Manipulation and Home Exercise with Advice for Subacute and Chronic Back-Related Leg Pain, a trial with adaptive allocation published in Annals of Internal Medicine in 2014. Hopefully, for those following low back pain research, these authors are familiar. It was in fact conducted at two institution-affiliated research clinics at Northwestern Health Sciences University and Palmer College of Chiropractic in Davenport, Iowa. The study was funded by the U.S. Department of Health and Human Services. So who were the patients? Well, the inclusion criteria were classifications 2, 3, 4, and 6 using the Quebec Task Force on Spinal Disorders, which includes individuals with radiating pain into the proximal or distal part of the lower extremity, with or without neurologic signs. Patients who were 21 years or older, had leg pain severity of 3 or greater, a current episode of 4 weeks or more, and a stable prescription medication plan in the previous month. Exclusion criteria were those participants rated as classifications of 1, 5, 7, 8, 9, 10, and 11 using the Quebec Task Force on Spinal Disorders, which includes pain without radiation into the lower extremities, or the other end of the spectrum, those with serious conditions. As an illustration of how difficult it is to do research that generates a large enough group to be statistically relevant, out of 1,132 patients contacted by phone, 940 patients were excluded. 564 did not meet the inclusion criteria, 353 declined to participate, and 23 were not available for the scheduled baseline evaluation. There were 192 patients finally enrolled, with 70 at the Iowa site and 122 at the Minnesota site. The two groups were home exercise and advice and spinal manipulation plus home exercise with advice. There was no control group. Outcome measures were standard using the Modified Rowland-Morris Disability Questionnaire, the physical and mental health status for the SF-36, patient satisfaction, global improvement, and frequency of medication used for back and leg pain in the past week. Additionally, patients' expectations about treatment and expected side effects were measured using a self-report questionnaire. Data was collected at the primary endpoint of 12 weeks when the intervention ended and at the 52-week follow-up. Response regarding data collection were remarkable, with 191 participants, or 99%, providing follow-up data at 12 weeks, and 179 participants, or 93%, at 52 weeks. The researchers also collected biomechanical and clinical objective data, including a straight leg raise, muscle endurance testing, three-dimensional lumbar motion, standing postural sway, sudden load response, self-reported fear avoidance, and self-efficacy. There were 7 chiropractors, 5 exercise therapists, and 1 personal trainer who provided the home exercise and advice intervention. As many as 20 SMT visits were allowed, each lasting 10 to 20 minutes. Patients assigned to the SMT plus home exercise advice group also attended 4 HEA visits. Treatment included high-velocity, low-amplitude thrust procedures or low-velocity, variable amplitude mobilization techniques. Chiropractors asked patients about exercise adherence and encouraged them to comply. The mean number of HEA visits was about 4, and the mean number of SMT plus HEA visits was around 15. Home exercise and advice were provided in 4 one-hour, one-on-one visits during the 12-week intervention. The focus was on positioning and stabilization exercises. The stabilization exercises included a pelvic tilt, quadruped, bridging, abdominal curl-ups, and side bridging. Patients were instructed to do 8 to 12 repetitions of each stabilization exercise every other day. Patients were also given approaches for developing spine posture awareness related to their activities of daily living. The results? After 12 weeks of intervention, there was an advantage for those in the SMT plus HEA group over those in the HEA only group, with a 10 percentage point advantage. However, there was no statistical advantage at the 52-week follow-up. It was a 7 percentage point advantage, but with a poor p-value. The SMT plus HEA group had better extension trunk endurance. However, there were no other strength differences found between groups. Let's look at baseline pain levels to see the actual degree of change. Here we can see that on average, the leg pain was a mean of around 5.2 to 5.4. The improvement at both 12 weeks and 1 year was only to about a 3 from a baseline of 5.4 for the SMT plus HEA group, and for the HEA only group, down to about a 3.7 from a baseline of 5.4. It's interesting that, on average, this was perceived as clinically significant by the patients. For the absolute reduction in leg pain, the numbers are at 12 weeks for the SMT plus HEA group, 60% had a 50% reduction, 37% had a 75% reduction, and 20% had a 100% reduction, compared to the HEA group, where 44% had a 50% reduction, 19% had a 75% reduction, and only 5% had a 100% reduction. And at the 1 year follow-up for the SMT plus HEA group, 54% had a 50% reduction, 35% had a 75% reduction, and 23% had a 100% reduction, compared to the HEA only group, where 45% had a 50% reduction, 22% had a 75% reduction, and only 12% had a 100% reduction. At 12 weeks, the adjusted means in the SMT plus HEA group were better than those in the HEA group alone. For low back pain, it was a difference of 9 percentage points. For disability, a difference of 11 percentage points. For the SF36 physical component score, a difference of 3.4 points. And for global improvement, a difference of 10 points. Satisfaction scores showed a difference of 11 percentage points. So what happens to patients after a trial of 4 months when the intervention actually stops? Well, at 1 year, 81 patients, or 42% out of the 192 patients in the study, had sought additional health care, 38 in the SMT plus HEA group and 43 in the HEA only group. Patients still using medication for leg or back pain at 12 weeks totaled 56% for the SMT plus HEA group versus 61% for the HEA only group, and 42% versus 66% at week 52 respectively. This is rather disappointing, with around 60% still symptomatic enough to need care, and when compared to those who had at least 75% absolute reduction in leg pain, it's similar as seen in the previous graph at about 35%. As usual, there are unanswered questions and questions raised by these results. We don't know what proportion of individuals had disc-related leg pain versus referred. Logically, it would seem that the disc-related cases would represent those that improved the least, but we don't know. The follow-up for exercise seemed to end at the 12-week evaluation, so we really don't know if there are differences between the two groups with regard to compliance to their exercise program, and so therefore don't know what effect that might have had on the 52-week follow-up data. Previous studies and a Cochrane review have suggested that the best time to implement an exercise regimen would be after the low back pain and leg pain have improved. For recurrences of low back pain, the Cochrane reviews seem to indicate that there was value in exercise performance, but only after the low back pain resolved. So perhaps the assumption of this design to include exercise as a benefit to symptomatic patients is flawed. The authors of this most recent publication are well known for their research in this area over the last few years. Comparisons in their previous publications have been made between SMT groups and exercise groups, both for low back and for neck pain. Their findings seem fairly consistent with this current study that indicates short-term results are always better than the long-term follow-ups, and that when starting with a mid-range pain score, results are never as impressive as one would hope. We do know that from this study and others before it that HVLA manipulation is a safe procedure for patients with low back pain with leg pain. This very important safety issue will hopefully be made evident to medical physicians given this publication is in the Annals of Internal Medicine. Also, keep in mind that the North American Spine Society has included manipulation as an option for those with disc-related low back pain in their 2014 consensus document.